Excellent. All right, welcome to our pharmacology review for psychotherapeutic drugs. Today, we will have a very interesting class, and we will talk about psychiatric disorders. Oh, where is my pen tablet? I always forget pen tablets. Okay, just a moment. Oh my God. I think it's a problem. How do I remember these pen tablets? Okay. Okay, I'm ready. Okay, so psychiatric disorders. So mental disorders, psychiatric disorders, and this is something that we are going to develop during the day today. And for that, we need to have basically some general parameters in order to, who's coming in? Somebody's asking to come in. Mia, okay. Okay, Mia, welcome again. Okay. So we will talk about anxiety disorders and affective disorders. Okay, so there is the main two groups that are, and this classification has been changing through the years because there have been including, excluding some pathologies, but this is what you're going to see in NCLEX, okay, in HESI, and nursing in general. This is what is actualized right now. All right, so here we have the psychiatric disorder. So for this, you can start applying this at home. Where is my pen? Oh God, where is the pen? Oh, here. All right, so do you know that there is some indicators that you can tell patient have some mental or psychiatric disorders, or high risk to have psychiatric disorders? So I'm going to mention those risks, and I just want you to look around yourself, right? So probably you can identify people with these situations. We are going to talk about, for example, the risk that you can have in in a few years or in the long run. Some mental psychiatric disorders is when, for example, you have very extreme all the time anxiety. Listen, please. Anxiety is different to say anxiety disorder. Okay, so we are going to explain that. It's going to be very clear. Second, they have extreme mood changes. So those mood changes, that means the behavior, personality of the patient are being changing. Number three, they are going to suffer from isolation. They are going to isolate themselves. Four, changes on the eating, and changes on the sleep. Are you sleeping okay? Are you eating okay? If you feel that you want to be alone, somebody is telling you why you're so moody, or actually you have these problems that you don't know how to resolve. All right, so those are basically something that you need to control, and that the only way to control that is based on positive thoughts. If you have something negative, from something negative, always is coming something positive. Okay, so you cannot go deeper than that. Okay, so based on that introduction, we are going to talk about anxiety disorders. And talking about anxiety disorders, we are going to it's going to be characterized by anxiety and fear. All right, so anxiety disorders, anxiety. So you're talking about anxiety or anxiety disorders, or you're telling me anxiety disorders is the same as anxiety. So confusing, right? So anxiety disorder is a group of diseases, a group, anxiety disorder. Anxiety disorders, under that anxiety disorder is a big group, is the group. When you said anxiety disorder is one of these. It could be, for example, anxiety itself. Anxiety. Yes, anxiety, period, nothing else. So anxiety disorder is not the same to say anxiety. Anxiety is the anxiety itself. Anxiety disorder means a more comprehensive. Okay? You have, for example, panic attacks, another that is anxiety disorder. Yes, now it's getting clear. Then we have, for example, phobias, right? Phobias. So those are basically one of the most important components of anxiety disorders. And for that, we are going to give anti-anxiety medication. All right, so affective disorders. In affective disorder, we have abnormal disturbances of the mood, extreme or inappropriate emotions. And that is going to be, for example, you have anxiety disorder for one side, and we have affective disorders, and that is going to be basically three of them. Number one will be bipolar, number two, schizophrenia, and number three, depression. So those three are going to be under affective disorders. And I have here some summary here. Well, okay, so let's see. All right, so we have psychiatric disorders, anxiety disorders, affective disorders. That is what we just make the classification, and that is what we have here in under anxiety disorder. So anxiety disorder. So whatever treatment is going to receive this patient is anti-anxiety medication. Okay, anxiolytics, anxiolytics, anxiolytics. What means anxiolytic? Anxiolytic, yeah, anxiolytic, yes, anxiolytic. Anxiolytic means that they are going anxiety lytics. So they are lytics, anxiolytic, anxiolytic, anxiolytic with I. My God, okay. Anxiolytic. Anxiolytic means anxiety, lytic means destruction. So it means you're going to get rid of the anxiety. So you already know what is the difference between anxiety and stress, right? So very quick, tell me please. Somebody, every
Stress is you know what to do. Anxiety is you have a problem but you don't know how to solve it.
exactly. That is anxiety. Very clear. But excellent. Okay. And for that, we are going to talk about anxiolytics or anti-anxiety medications. Okay. All right. So then we are going to see the affective disorders. The affective disorders will be the psychotic disorders like schizophrenia. We have five type of schizophrenia, but we are going to talk in general about schizophrenia. So this is not a clinical, I mean, a study about the types of schizophrenia. We are talking about pharmacology and nursing considerations. And mood disorders, we have the depression and bipolar. Okay, so what does it mean schizophrenia? Schizo means division, 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 division. Schizo means division. Phrenia means personality. Phrenia means personality. So schizophrenia means a patient who have a divided personality, a dual personality. Okay, that basically is going to have an unrealistic perception of what is going around. So it's totally being deorganized. Okay, so we will talk about that in a little bit. Depression, the other side. So we have you're high, schizophrenia, low, depression, and bipolar basically is in between. Because bipolar have this bipolar, the maniac depressive disorder is a maniac depressive disorder where we have one time is being very active and another time very depressed. So go to both extremes. Is the bipolar. Okay, and for that we are going to just remember affective disorders. Okay, so if you remember affective disorders will be the schizophrenia and depression and bipolar. So if you remember that way, so you can call mood disorder. When you talk about mood disorders, you're talking about bipolar, depression. When you're talking about psychotic disorders, are going to be called basically schizophrenia. Okay. Okay, so now very fast in here because we need to finish this introduction. The psychiatric disorders, three major neurotransmitters. Three major neurotransmitters. Okay, so please, very straight. We have neurotransmitters, proteins produced by the nerve cells, transmitted by action potential, etc., etc., etc. So these neurotransmitters produced by the nerve cells have dual activity. Dual activity depends. So they have two different activities. One activity when the neurotransmitter is acting at the level of the central nervous system, all the brain and the spinal cord, central nervous system. And another activity these neurotransmitters will have in the peripheral nervous system, peripherally. For example, we have the adrenaline. Adrenaline is a neurotransmitter, to say the most common or the most familiar. And this adrenaline in the brain, what it's going to do is to give you the alertness. You want proof of that? Okay, let's have a proof. Tell me, do you have those situations that you are very stressed out, extremely stressed out? You don't know for in the past you didn't know how to resolve the problem. But at the moment that you're facing the problem and you are so stressed out, you're nervous, actually for some reason or somehow you resolve the problem and you said, I don't know how I did it, I was so stressed out. That happened to you or not?
Yeah.
Yes.
Yes, yes,
Yeah.
happened to everybody, and that means that adrenaline was increased. So adrenaline increase is going to accelerate all your cognitive, your alertness, your in fight or flight. You're going to escape. You feel threat, and you want to find a solution. So that's why adrenaline in the central nervous system. But in the peripheral nervous system, the adrenaline, what is going to do are the alpha ones, alpha 2, beta 1, and beta 2. Produce the vasoconstriction, produce the bronchodilation, produce the heart rate going up, the blood pressure go up, the contractility go up, peripheral resistance go up. Be okay with that? Okay? So, and that happened with the dopamine, serotonin, and the norepinephrine. So any neurotransmitter you have, glutamate, dopamine, GABA, acetylcholine, everything is going to have dual activity. One in the central, another one in the peripheral. Acetylcholine, for example, you need acetylcholine to be alert, to focus when it's acting in the central nervous system. But when you are in the peripheral nervous system, the acetylcholine is going to be the giant cat, muscle contraction. Okay with that? The serotonin, for example, the serotonin, norepinephrine is similar to adrenaline. What is the difference between norepinephrine and adrenaline, and why we have here talking about norepinephrine? Norepinephrine is from all the adrenergic agents. The strongest is the noradrenaline or norepinephrine. You know, norepinephrine, noradrenaline is the same, right? Stronger than the adrenaline. So why we use more adrenaline instead of noradrenaline? Why? Because even though the noradrenaline is stronger, more potent than adrenaline, the noradrenaline lasts basically 1/4, very short period of time compared to the adrenaline. We okay with that?
Yes.
Okay, so let me put my camera because cameras, everybody. Yes. Thank you. Do you hear the storm today? Storm, right? It was horrible.
Yeah.
That's nice. Okay, so that is about norepinephrine and adrenaline. Now let's talk about serotonin very fast. Serotonin in the central nervous system is basically the reward, the happiness, is the mood hormone of the mood for the mood. So if you have normal levels of serotonin, you're going to have actually you feel comfortable, you feel happy, you feel okay, calm. But if you have low levels of serotonin, you can get into depression. That is in the central nervous system. But in the serotonin in the peripheral nervous system, for example, you know that 97% of the serotonin is produced by the walls of the intestines. That is where 75%, 97, no, 75%, yes, of that serotonin of the body is produced in the intestine. Serotonin can go to the central nervous system, is the mood regulator, and in the intestine, what is doing? Peristalsis. Yes, it's doing the peristalsis. So when you have the serotoninergic toxicity, what is going to happen? One of the things is going to cause diarrhea, plus other things that we will see in the next few slides. So why you have excess of serotonin? Because if you are depressed, what you're going to take? You're going to take serotonin, right? Okay. Dopamine, the dopamine again, central and peripheral. Dopamine in the peripheral nervous system, what is going to what is the effect? Is a vasopressor. Remember, dopamine, epinephrine, and norepinephrine, those are catecholamines. Dopamine is produced by the body. By whom? It's going to be by the adrenal gland, and it's going to be produced by the basal ganglia, substantia nigra, on the side by side of the diencephalon that we review and we know from Parkinson, right? So in Parkinson, this central activity is going to be translated into motor activity in upper, lower extremities, etc. But it's central. But in the peripheral, that means arteries and veins, what is producing is a vasoconstriction. So dopamine can increase the blood pressure. Okay? Dopamine is called the reward hormone. Serotonin is the mood hormone. Okay, serotonin the mood, and dopamine the what? The reward. Reward, for example, whatever is giving you pleasure. For example, music. You want to eat something that you like. Dopamine. You want that music. Dopamine. You see the landscape, or you walking. That is a reward. Dopamine. You take a cigarette. That is rewarding. So all those are reward. Okay. All right. So synapses. I don't want to go over. You want Serengeti River? No, right? No. No one Serengeti River? Serengeti River, no? Hello? Hello?
What are you?
You want me to talk about Serengeti River or no? Or it's clear?
No, I think it's clear.
No? Okay. I like that. But anyhow, okay, next time. All right. So here we have the norepinephrine. What it's doing in the central nervous system is no hesitation. So that make you more kind of making decisions, right? You got an alert. You're going to be actually improving your memory. So what is doing the serotonin in the central nervous system? Sleep, emotion, remember, right? Mood disorder. Dopamine, determination, obsession, the pleasure. So you see here these three neurotransmitters. Why I'm talking about these neurotransmitters, right? So besides that, we have in common things that are going to be attention, anxiety, appetite, sex appetite, aggression, mood cognition. So all these are going to be part of your behavior, Okay, so dopamine, here we have in the peripheral nervous system, the reward hormone, vasopressor. This is the action in the central nervous system. And the deficit of dopamine will lead into depression, right? And excess into schizophrenia. Serotonin, peripheral nervous system, increase GI tract motility. If you have excess of serotonin, they can lead into diarrheas, for example. In the central nervous system, this is the reward hormone, the mood hormone, and they are going to participate in the central nervous system as the mood hormone. So you're happy, you feel comfortable. Deficit is the depression, serotonin, and excess the schizophrenia. Norepinephrine, levofit, please, is a common name in HESI, okay? norepinephrine as a catecholamine, that is a vasopressor, right? It's stimulating the dopamine receptors. So the dopamine receptors are different from the alpha 1, alpha 2, beta 1, beta 2. So, but what they are doing, these receptors, is produce vasoconstriction in different manner, with different receptors. All right, so that is what is doing the central nervous system. Deficit is depression, excess, psychotic relapse, or contribute to the schizophrenia. So in conclusion, look at that. In conclusion, we have that what is doing anxiety and depression, put you down. What is doing schizophrenia and bipolar in the stage of maniac, that is going to increase. So in conclusion, what I'm trying to tell you is this: pharmacology. So if you have the serotonin, you have the dopamine, you have the norepinephrine, okay, acetylcholine too is included here, that are going to be low. Low means depression, all right? Anxiety later on can lead you into depression because you cannot resolve the problem. You give up, right? So, and if you have these neurotransmitters down because of the anxiety, what we are trying to do, the treatment will be to increase those neurotransmitters. On the other hand, we have schizophrenia and bipolar. In bipolar, what we have is a very chaotic production, increased production of these neurotransmitters. So you have too much of these neurotransmitters. And this having too much means that you're going to have these problems, schizophrenia, bipolar. And what we need to do? We need to do to block, to decrease basically the production or the activity of these neurotransmitters. So schizophrenia, too high. So you need to, the treatment will be to lower those neurotransmitters. Depression, anxiety, your neurotransmitters are low. So what we need to do is to increase the drugs. Okay with that? Right? So that is the general principle of what we are going to see today. All right? Anti-anxiety. Anti-anxiety medication is called minor tranquilizer. Minor tranquilizer. Antipsychotics are going to be the major tranquilizer. Antidepressive, we have all these three. We were talking pharmacology today. So anxiety, we already talked about anxiety. All right, so I'm going to go that later. So anxiety, we have all this classification. Okay, and please, I want to ask you something. This is a general for you, okay? What means personality? Personality is behavior or no? What is personality? Your personality is changing, and there's a lot of changes in personality in these patients. Okay, so what is that? It's going to be how proactive you are. So personality. You know somebody, and this somebody, it's a good personality. It's a bad personality. So what you are assessing here, you're assessing how the patient is doing things, how intelligent is the patient, what is the taste, so what are they like, what kind of things. So all these together are going to be basically together the personality of the patient. And there are variations of personality. Okay, the willing to do things, the intellectual activity, personality, and the taste. That is basically the three main components of personality. So everybody has personality. You cannot say this person doesn't have personality. No, everybody has personality. That there's variations, of course. Okay, all right. Any question?
No.
So now, if you know somebody, all right, a friend or family or somebody in the work, whatever, personality, assess the personality. Possess the personality is how intelligent it is, how proactive are to do this for the behavior, and the taste. So that is basically the three main group of personality. All right, so let's keep going. Anti-anxiety medications, we are going to have the TCA is the tricyclic antidepressive medication is used for anti-anxiety. We have the SSRI, we have the MAO inhibitors, and we have the atypical antidepressants. We are going to talk about that is being used for depression and it can be used for anxiety. And we are going to talk about the queen here is the benzodiazepines. The benzodiazepines. Okay? All right, so let's start. The benzodiazepines. The benzodiazepines, what they're doing, these guys, is very important. Benzodiazepine. So that is an anxiolytic. 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 Yes, anxiolytic. Anxiolytic or actually a minor antidepressant. It's called minor antidepressant. All right, so now we start antidepressant. So these benzodiazepines are going to be in low doses and they're going to be for anxiety. And for high doses are going to be used as anti-seizure. All right, so these benzodiazepines are going to be, there's some range of doses. If you have and this can be used for sleep disorders. So there is two things here, anti-anxiety and for sleep disorder. So what is doing basically the anxiolytics to kill the anxiety? What means to diminish anxiety? Means to calm the patient, to calm down the patient. That is what is doing the benzodiazepines in this low dose. When you increase the dose, that they're going to produce or induce a sleep that is called hypnotic effect. Hypnotic, very important, very common in the exams. Hypnotic. So we have two sides: to calm the patient or calm action or hypnotic action. What means hypnotic? Hypnotic means it's not a drink, right? So you know the drink, right? So the drink is hypnotic means induced to sleep. Induced to sleep. So what is doing these benzodiazepines? The benzodiazepines is going to stimulate the release of GABA. GABA is an inhibitory neurotransmitter. It's something that is going to calm you down, to slow you down. They can be used, as I mentioned here, as anticonvulsants. Anticonvulsants is called AED. That is anti-epileptic drug, part of that. Mostly we use benzodiazepines when you have a crisis and you need to stop the seizures and convulsions, and that means that you can give diazepam, for example, 5 milligrams IV in 5 minutes. So that is going to calm down the seizures. Anti-anxiety medication, it can be sedative or calm sedative. So you can use sedative is more technical word than calm the patient. Sedative, and the other one is when you have higher levels, is going to behave as hypnotic. Other uses, the benzodiazepines, especially the midazolam, that we are going to see the names very soon, are going to be for preoperative sedative conscious sedation. What does it mean? That means, for example, if you're going to have, I'll give you an example, endoscopy. Endoscopy means upper endoscopy. They put your tube through the throat, go to the esophagus, go to the stomach to check how is your stomach for whatever reason. For that, you need to be sedated. Oh, yes, sedated. You need to be sedated. A sedated means is, but why they don't make you sleep and knock you down in order just to do whatever, right? So whatever they need to do. So why? Because during the procedure, you need to be semi-conscious in order to follow orders. And most of the time, you don't remember what happened, but you still responding to external stimulus. You okay with that? So benzodiazepines, they have multiple what if multiple what actions. All right. So side effects, we have they have amnesia, very characteristic amnesia. So you forgot. We have recent loss of memory. So you forgot what you was doing hours before, or it's difficult for you to remember that. That is what we call the hangover of the benzodiazepines. Okay. Now, one thing I want you to remember, always remember, is hepatotoxic. Question for NCLEX. Hepatotoxicity, the benzodiazepines. Okay. So the benzodiazepines, they are going to be used maximum for 4 weeks. 4 weeks, maximum. Is not for long-term use. Not for long-term use. Not for long-term use. They can produce some addiction. They can produce some adherence to the. They can produce some addiction. It's addictive. And never any of these drugs. That is for all medication that we are going to see, the 40 medication that we'll see today, never stop abruptly. Never any of these. No anti-anxiety, antidepressants, schizophrenia, anti-seizure, no. Never stop abruptly. That is very common question for NCLEX. Never stop abruptly. Because what happens, there can happen a rebound effect. In this case, if you are using for sleep disorders, you're going to have a rebound insomnia. All right, so nursing considerations, we use the benzodiazepines for alcoholics, for basically and that makes sense because the patient is trying to stop the drinking and they enter into anxiety. And in order to calm down the anxiety, in order to prevent them to come back to start drinking, you're going to give some benzodiazepines, so the anxiety, okay? Now, smokers, all these are potential questions. So every square I see you put here, okay? All right, so in this case, let's finish this. Best route intramuscular. Why best route intramuscular? Because that the most common is the oxazepam. Oxazepam is is intramuscular, so it's very fast, very active, very rapid effect. And why? Because the patient in withdrawal syndrome, you need to know that they are nauseous and vomiting. They have nauseous and vomiting. And this nauseous and vomiting can, if you're PO, they're going to vomit the pill, so it's not going to be effective. So the best thing is to intramuscular, okay? IV could be okay, but the patient is probably moving, agitated, and is not recommended. So intramuscular is faster than to apply the IV. Of course, the IV, if you have an access, the effect is going to be mostly immediate. But the patient is agitated, so you don't want to go through that. So you go intramuscular. Smokers, again, smokers and smokers and smokers. So you have anxiolytic, and the anxiolytic, the benzodiazepine, are going to decrease the effect because of the smoking. It's going to decrease the effect when you smoke. So patients say, are you taking this medication? Well, nothing happened, but this is smoking all day. So obviously the benzodiazepines are going to, because the nicotine is somehow stimulate the person, the patient, and the benzodiazepine is doing the opposite. So they are not going to be good friends. Evaluation. Patient reports sleeping better and increased interest of activities, so anxiety, right? So here we have some names. So are going to just give you some way to memorize that. We have the diazepam, we have the midazolam, flurazepam, alprazolam, lorazepam, oxazepam. If you see here, we have LAM and PAM. LAM and PAM. We talk about this when we was talking about substance abuse. Remember that? LAM and PAM. All right, so the antidote that you always must remember is the flumazenil. Flumazenil. Don't get tricked on the exam. So it's not the naloxone. The naloxone or naltrexone, naloxone. What is the naloxone? Naltrexone. What is naltrexone? It's the antidote for what?
Morphine?
Excellent. For morphine. It's the antidote for morphine. This nothing to do with this. Okay? Benzodiazepine is the flumazenil. Remember, just to remind you a little bit, we was talking about the flunitrazepam, that is the Rufus drug, the rape data drug, right? Remember, the antidote will be the flumazenil. All right, so we need to taper if that is taking equal or more than 4 weeks. You need to taper off. You need to taper off the medication, otherwise it can produce a rebound effect. Okay? Do not abruptly stop this drug after long term because they can cause symptoms of similar to alcohol withdrawal. Okay? Monitor the LFTs. Why? Why monitor LFTs? Why? Why? Hepatotoxic. Remember, we was drawing the liver. Hepatotoxic, right? So you need to take it before to go to bed because they basically is going to make you low. It's going to slow you down. So you want to be slow during the day or at the time you're going to sleep, right? Avoid alcohol because they can compete with receptors and can make summation. They are going to basically make a summation because alcohol is a depressor. Benzodiazepine is going to be a depressor too. So they are going to make summation of the action. Obviously, we need to look for safety precautions for driving and operating machinery. Okay, so this is the buspirone. So this is the no benzodiazepines. So that is not, buspirone is not a benzodiazepine. It's called a no benzodiazepine. That is the azaspirone. So these names I'm not going to ask you not much, but buspirone, yes. Buspirone. Buspirone is going to be are going to partial serotonin and dopamine agonist, so it's going to improve your mood, improve your activity. Uses for anxiety, it's anti-anxiety medication. Not for depression of OCD or schizo, don't have the anticonvulsant effect of the benzos. So these buspirone do not have the effect of anti-seizures. Remember, benzodiazepines. Do you know somebody with benzodiazepines? So they take him because I feel anxious. I cannot, I don't know, I feel something is going to happen and I don't know what is that. So I don't understand myself. So anxiety. You cannot sleep. They give you medication, but the dose is going to be a little bit higher, right? So to induce sleep. So benzodiazepines, if you are stressed, you cannot sleep. So these calm down your anxiety and that help you. So that means that the normal doses, this medication is not a sleeping pill. It's not a sleeping pill. If you increase the dose, yes, that is going to lead into a sleeping effect, sleep effect. Okay, the problem with this is a very good medication, and listen, buspirone can be used for long term, can be used for long term, can be used for long term, because there is no addiction like benzodiazepines. They do not have the tolerance. So sometimes, the benzodiazepines, with the time, they are going to start losing the effect because they have a tolerance effect. Tolerance effect. The more time you take the benzodiazepines, the liver are going to metabolize faster. So you will need more and more dose to have the same effect. There is a moment that you have so much of these benzodiazepines that you reach toxic levels, and you don't want to do that. So the benzodiazepines, short period of time. The buspirone is going to be long-term use. Benzodiazepines, Mercedes-Benz, you go fast. Okay, you go fast, and it's a very fast action. The buspirone is a bus. Compete a Mercedes-Benz with a bus. The bus is going to take more time to reach the place. So that's why the benzodiazepines is going to be effective in few hours. Meantime, the buspirone can make effect in about a week, 2 weeks. We need to wait 2 weeks to just kick in the medication. Okay?
Okay.
Okay. Thank you. All right, so here we have the hydroxyzine. Hydroxyzine is an antihistaminic. And that is, do you see the Unison in the market? Unison? Do you see this area that says sleep aid?
Yes.
Right?
Yeah.
The sleep aid, that is basically mostly are those histamine, the hydroxyzine. Why hydroxyzine? Why? Because it's better for absorption, less side effects. Benadryl, the diphenhydramine, they can produce drowsiness too, but hydroxyzine, they have a better pharmacokinetics than the Benadryl in order on the absorption, pharmacokinetics. All right, so we have hydroxyzine, mild tranquilizer, anxiety, tension, relaxation before surgery. That is an antihistaminic. So they produce this drowsiness. They have, in addition to that, antihistaminics, write it down, these are going to have always some anticholinergic effect. They are not considered full anticholinergic. They have some of the anticholinergic effect present. The most important action of this medication is to block the new production of histamine. I said the new production of histamine. They're not going to block the already circulating histamine in your blood. Okay? So in this case, we talk about two drugs that you need to remember for anxiety: the benzos and no benzos. Okay, so the benzodiazepines are going to show you how to memorize that. Let me go here. I was working on that yesterday. No, this is not. Oh my God. What? Okay. Excuse me. Here, of course. Okay. Okay, so here we have the benzodiazepines. Okay, so it's diazepam, oxazepam, chlordiazepoxide, temazepam, clonazepam, lorazepam, and midazolam. So all these need to be memorized in the spot today. Okay, so I try to create some mnemonic here, and I'm going to make you repeat it only one time. Okay, so when you are having anxiety, where do you go? You go to the doctor, right? Yes or no?
Yes.
And when you go to
Yes.
the doctor is you expect them to feel calm, correct? Yes.
Yes.
So you go to the doctor to be calm. Okay, so benzodiazepines, anti-anxiety. You go to the doctor to get calm. So here we have D as a doctor, diazepam, O as oxazepam, C chlordiazepoxide. That is the Librium. It's the most oldest of all these benzos. Temazepam, DOCT, DOCT. And the DOCT is going to calm you down. Clonazepam, alprazolam, lorazepam, midazolam. Okay, so with that you have 99.9999 of the drugs that they are going to can be asked. Okay, can you repeat this for me, please? DOCT, calm. D, what is D? Everybody.
Diazepam,
What is O?
oxazepam,
Oxazepam. Everybody, please. Mia, Anna, and everybody, please. Chlor. Okay, this is the hard one. Chlordiazepoxide. Say it.
chlordiazepoxide,
Oxide.
Yeah, you are. Yes. Then T. Give me the T.
temazepam,
Everybody, please. Temazepam.
Pen.
Diazepam.
Clonazepam.
clonazepam,
Alprazolam.
alprazolam,
Lorazepam.
Lorazepam.
lorazepam,
And midazolam.
Midazolam.
Midazolam. Okay, so we have 1, 2, 3, 4, 5, 6, 7, 8. There is 32 to go. Okay, but 8 is the first group. You okay with that? Doct, calm. You go to the doctor to calm. So that is how you remember the names of the benzodiazepines. You okay with that?
Yes.
Thank you.
Okay. So now the other treatment for anxiety will be the buspirone. The buspirone. How to remember buspirone and benzodiazepines for anti-anxiety. You have the Mercedes-Benz running against the bus. You okay with that?
Yes.
So fast action. You need to do it for short period of time, the benzos. But if you compare the bus and the Mercedes-Benz, who is going to go faster? The Mercedes-Benz, and slow the buspirone. The buspirone basically is that they are going to sedative effect, but do not have the bad scenes or not the so good scenes from the not the bad scenes from the benzodiazepines. For example, they do not create dependence. They do not create dependence. You don't need to taper off. The problem with the bus is that go slow, so it's going to kick in about 2 to 4 weeks, 2 weeks. Meantime, the benzodiazepines are going to kick in few hours. You okay with that? Nice, right? You like it?
Yes.
Okay, so that is about anti-anxiety medication. We are going to go over that again. So tell me if you need a break or not.
Yes.
You need a break?
Yes.
Why you need a break? Okay, that's okay. That's fine. All right. So 11:10.
Thank you.
Thank you. Hello?
Hi, Dr. G.
Hello.
Hello. What am I going to do? Oh, I'm peeing myself. Because I want to see everybody. Okay. Cameras, please. Just a moment. My eyes. I think my cats were scared. Banusha, my little one, he never saw hear a storm. He was running on me to hide under my blanket. Okay. All right, so let's continue. All right, so I need to make a small correction here. Okay, so we have, for anxiolytics, I want just to give you the big picture because we are going to talk about that again. Benzodiazepines in the next pathology. So, anti-anxiety, you can use all these medications, okay? So, because anxiety depends the level of anxiety, right? So, if you are not, it's not working with one medication, they pass to another medication. But the two main medications are going to be the benzodiazepines, and the other one is not called no benzos, it's called the azaspiridones. So just remember the buspirone, the buspirone. Okay, so that is the only correction. Okay, so in conclusion, you have a patient in front of you with anxiety. Okay, benzodiazepines. That is not going to work. You want to go for a long period of time. You're going to use the buspirone. You okay with that? Now, if that is going to be moderate to severe, anxiety is the mother and the father of all the mental disorders. So you start to be stressed. And stress is different from anxiety. You're stressed, but that stress can be the beginning of anxiety because if the stress is for long periods of time, means that you couldn't find a solution. So that stress become anxiety. That anxiety is going to be the beginning of other pathologies like phobias, like a depression. And for that, you need to start adding medication. So basically, we tailor the medication to the patient. But for mild and some moderate anxiety problems, you're going to use the benzodiazepines, and you're going to use after that for a long period of time the buspirone. Okay, so never benzodiazepines for long periods of time, no more than 4 weeks. And when you stop the medication, you need to stop tapering the medication. Taper the medication. One thing is coming to my head is a patient complaining that they cannot. They taking these benzodiazepines and it's not making effect, so it's complaining. And actually, it could be a cause because the patient is a smoker. Smoking is going to decrease the effect of the benzodiazepines. You okay with that?
Yes.
Okay. All right, so let's talk about psychosis. So today we are going to talk about psychosis, and then we are going to talk about schizophrenia. Okay. Okay, so let's see. Psychosis. Psychosis disorder of the ability to interpret reality. So basically, the reality is different. So it's going to be associated with some additional words we are going to use. For example, we have hallucinations and delusions. So we are going to see that in a few moments. Most common psychotic disorder is schizophrenia. The goals treat acute episodes, prevent relapse, and maintain the highest level of the functions of the patient. So here we have, during these affective disorders, we have the psychotic disorder, and we have the here called schizophrenia. There is 5 types of schizophrenia. Okay, So we are not going to talk about all of them, schizoaffective, etc. So there's different types. All right, so let's start. Psychosis criteria, hallucinations. So you need to differentiate what is a hallucination from delusion. Delusion is fixation of ideas. Okay, so you're going to have an interpretation of the reality. The most common example will be somebody is trying to kill me. Somebody is trying to kill me. So somebody's trying to kill you. Okay, so well, nobody's here to kill you. No, but it's in the other room. Okay, let's go to the other room. There's somebody trying to kill you. And we go to the other room, nobody's there. And the patient said, okay, it's not here. Probably it's outside the house. It's waiting for me. Okay, let's go outside. There is no there. So, oh, no, because it's on the corner, on the other street. Okay, and that is going to be a continuous fixation of idea. So that is a different interpretation of the reality. Okay, you okay with that? Okay. All right, so for example, here we have hallucinations, sensory perception. Hallucination is different from delusion. Hallucination is everything that is happening for you, but is not exist at all. And that is perceived by your senses. So you can see, or you can smell, or you can taste, or you can feel, you can see, taste, smell, or you can feel on your body. So, for example, hallucinations will be happening in the withdrawal syndrome. Just to review a little bit what we was doing in the past about drug abuse. Hallucinations will be, for example, you start to feel that the cockroach are walking on your skin. Cockroach. But you see there is no any cockroach. Cockroach is very common to hear cockroach, okay? Some people say insects, but cockroach is the most common that you see in withdrawal syndrome. So the patient start to shake, start to sweat, and start to have feeling, start to do this like crazy because there's a cockroach walking on that is the perceptual sensation, right, in the skin. Then you can see, for example, you are sitting down and you see, oh, there is somebody is passing the wall. Somebody is passing the wall. So I saw somebody just going there. Oh, somebody said, oh, I see chickens walking close to me. Oh, look at that chicken. So those are hallucinations, visual hallucination, characteristic of psychosis, okay? Another thing, you can smell, oh, I smell acid all the time. Acid, but where is the acid? I don't smell any acid, right? Or bad smells, whatever, right? Or taste, somebody's trying to kill me. So this tastes like very ugly thing. So taste. And auditory, that is the most common, the auditory. The auditory means that you have in the radio or you have the TV, and they said, somebody said, oh, in the TV is telling me that we need to be careful because somebody's coming to kill us. But basically, if you see, all the hallucinations are negative. You don't have hallucinations that are positive. Oh, I'm walking on the park, or I'm flying. No, there's no flying. I don't know if it's positive or negative. Anyhow, so that is basically negative thoughts. We okay with that? That the thinking, so they cannot correlate. So basically, critical thinking is zero. So they're not able to correlate things one to, there's not even cause effect of things. The organized behavior, there are people very apprehensive. Apprehensive means that you talk to the patient to some topic, the patient start to cry. Or you talk about the same topic, and after a few moments, start to laugh like crazy. So that are problems of psychosis. Okay? Changes on the effect. I hate you, but I love you. Right? So is that normal? So you can hate and you can hate and you can love at the same time?
No.
No, really.
Yes.
No.
Yes, you can do. No, you cannot do that. It's like you're feeling cold and hot at the same time. Yes, you first, you look at this. You can hate somebody, but after few milliseconds, you think about, right? So you separate the hate to love. Yes, I love this guy or this person, right? And the opposite. I love you, but after a few moments, you say, I hate you because you did this, right? But you cannot hate and love simultaneously in the same box at the same time. You okay with that?
Yes.
Okay, and that mostly happen in girls 25 to 15 to 25 years old versus 25 to 35 on average. Those are the times. So 15 to 35, that is the time that mostly they have problems here. Okay. All right, so let's talk about the drugs. Antipsychotic. Antipsychotic, what it's going to do is you have excess. So in anxiety, depression, you have low, but in here, and psychotic patient is going to be too high. So what we need to is to decrease the neurotransmitters. Okay. All right, so here we have typical, the phenothiazines. So don't get confused with thiazides. Okay, thiazides is a diuretic. Okay, and this is basically the phenothiazines and the no phenothiazines. So from all these, I have kind of a problem in my head right now because I want to prepare you for your HESI and NCLEX for one side, but if I give you more detail, I'm going to basically teach you for overall, right? So comprehensive. But at this moment, I'm going to do a mix. I'm going to prepare you for HESI and for NCLEX, okay? And basically clinical application, of course, right? Like usual. So in this case, what I'm saying that if we have antipsychotic, we are going to have the haloperidol, that is the aldol, that is what I want you to get focused here. They're not going to ask you if this is phenothiazide or no phenothiazide. Just remember antipsychotic haloperidol. And we have the atypical. So you can choose, you can say typical is the haloperidol. And the atypical is going to be the ariprazole, olanzapine, risperidone, and the quitipine. So those are the two groups. So imagine a patient with psychosis right now in front of you. What you're taking? Oh, typical or atypical. So typical or atypical. So, schizophrenia, typical or atypical? Most likely they start with typical, the haloperidol. And the atypical, they're going to use the aripiprazole, olanzapine, risperidone, quetiapine. I couldn't find a mnemonic for that. I apologize for that. So just try to remember like a raw material of memorization. You need to get familiar with this, okay? All right, so we have drug interaction with antipsychotics. So just remember, we have everything high. So everything high. So everything high in the in patient with schizophrenia. So you need to lower. The treatment is to low down all these neurotransmitters. Okay. Now, if you take in these the antipsychotics of schizophrenia that is already lowering all your neurotransmitters, you can start having some interactions. For example, we have increased toxic effects. So if you take tranquilizers like buspirone and you have the benzodiazepines, is going to increase the effect, even toxic effect. Antihistaminic. When you take antihistaminic, you want to sleep, make you drowsy, yes or no, right? Alcohol is an antidepressor. And analgesics, they can actually produce that problem too. But basically, the ones who are piroxicam, meloxicam, basically some NSAIDs, and especially opioids. Opioids, those are central nervous system for pain, right? Opioids. It's central action, and the NSAIDs are going to be for what? For peripheral action, okay? Analgesics. Now, always high yield for what? For Encles and Hesse, Saint John's wort. Saint John's wort, you go to the Saint John in order to calm you down. So if you take these antipsychotics that are calming you down, if you take Saint John's wort, you go to Saint John's, they are going to calm you even more. So the effects are going to be more deeper. Okay? You okay with that?
Yes.
Okay, so that is one. The other ones I'm not going to mention because I'm going to mention that later. Okay, so the typical, we have the haloperidol. So that is the, we actually one, we have very potent. It's called the aldol, 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 aldol. What is doing? Okay, they're not going to ask you exactly the mechanism of action, but just to let you know, we have decreased dopamine, decreased serotonin. Why? Because they're too high, too high. Psychotic, too high. So they are going to decrease this neurotransmitter. And what is doing that? The haloperidol, most commonly called the haldol. Haldol. Okay? This is mostly used, please pay attention to that. Put 10 stars here for acute episodes. Acute episodes. We have the typical, we have the okay, we have the clozapine, olanzapine, QTIPAN, risperidone, and the aripiprazole. Aripiprazole. Somebody can make a mnemonic here. So coenzyme Q. No, what's it? Well, anyhow, Q10. Remember, there's well, anyhow, another time. Let's keep going. All right, so here we have for this typical the haloperidol or aldol can lead into extrapyramidal symptoms, and we have the neuroleptic malignant syndrome that is characterized by high temperature and can produce death of the patient. So neuroleptic malignant syndrome, we are going to see specifically some few slides on that. Here we have the atypical, the clozapine, olanzapine, QTIPAN, and risperidone are good. These guys, especially the clozapine, can produce weight gain. There you are, clozapine. Agranulocytosis, extrapyramidal symptoms. Please write down this. Agranulocytosis means low levels of granulocytes, who are the neutrophils, the eosinophils, and the basophils. So those are the three who contain granules. So that's why those are white cells. But you can, if you say leukopenia, or agranulocytosis means that there is no white cell, no neutrophil, no basophil, or low, neutro, baso, and eosinophils, right? Leukopenia is not a granulocytosis, okay? Leukopenia means all the white cells are low. In this case, we differentiate leukopenia from agranulocytosis. Granulocytosis will be high, but we said the agranulocytosis, absence of this granulocyte. For that, you need to do three things. Encles question, Hesse, very high yield. Number one, elevation of temperature. Temperature elevation. And sore throat. So coughing, sore throat. That could be an alert that something is going on because the respiratory infections are the most common. So who's coming? Who's coming late? Let's see who is this. Karen, do we accept her or no? Yeah? Can we?
Yes.
Okay. Okay, Karen, everybody accept you. Okay. All right, I need to find some kind of mnemonic here. So we already talked about typical and atypical. This is for dementia. So dopamine system stabilizer. We are going to see that soon. So just remember, so antipsychotic. All right, so imagine a patient with schizophrenia. So taking antipsychotics could be the haloperidol, or aldol, that is the typical, is for acute, right? And we have the atypical, could be the typical, clozapine, olanzapine, quetiapine, and risperidone. So you must need to be familiar with that. And basically what is common on them, they are going to be having extrapyramidal syndrome. So what is the extrapyramidal syndrome? Why? It's obvious. Look at this. Because they are blocking the dopamine. Dopamine is going down. That is not, when we're talking about Parkinson, remember? Remember that? Right?
Yes.
So that means if dopamine is going down, that is pseudo-Parkinsonism. Please don't think it's Parkinson. It's pseudo-Parkinsonism. Pseudo-Parkinsonism means it's the same. Pseudo-Parkinsonism is the same to say Parkinsonism, or to say the EPS, the extrapyramidal symptoms. Extrapyramidal symptoms is not Parkinson. Okay with that? It's going to have signs and symptoms of Parkinson, but it's not Parkinson. All right, so here we have antipsychotics. They are going to have very much here antipsychotics. We have anticholinergic effects. So you will see this patient is smoking because the mouth is always dry. They're trying to create saliva. So they have antipsychotics, have anticholinergic effect, dry mouth. Don't forget about the agranulocytosis, neuroleptic syndrome. We will see that high temperature in the next few moments. Temperature, photosensitivity, extrapyramidal. They can produce yellow skin, constipation, hypotension. So everything is going to be down. Everything is going to slow down. When you have too much, they're going to decrease the neurotransmitters, so you become slow. It's going to go down. Okay. So here we have drug use. Okay, so side effects. So you can see here we have sludge. This is a mnemonic I created a long time ago, but anyhow, it's still using. Sedative, lethargy, urinary retention. Like, why urinary retention? Because anticholinergic effect, right? Dry mouth, why? Because anticholinergic effect. Medication itself can lead into gastric acid increase. Energy loss, you start to slow down. Sedative, sludge. We okay with that?
Dr. G,
Yes.
which medication is this side effects for again?
General for
Oh,
all antipsychotics. So that is what is good here. Is general.
thank
So
you.
you can remember this if you want. Or this.
Thank you.
Okay. Okay. All right. So let's keep going. Neuroleptic malignant syndrome. Neuroleptic malignant syndrome basically happened with aldol. Okay. So idiopathic reaction of neuroleptic medication. So all these antipsychotics are neuroleptic, okay? Neuroleptic medication. Often occurs shortly after initiation of neuroleptic treatment after dose increase. So in this case, when you're going to have everything is high. So let's start with the vital signs. Increased temperature, 102, 103, 104. Your heart rate is going up. Your blood pressure going up. Rigidity. So the patient is become stiff, all right? So they can basically doing like this. So you look at me. I'm kind of okay. Okay, I'm okay. But then I start to be very tense, very straight, even my facial expression. So all your body start to be rigid. In addition to that, you have temperature, fever. You cannot miss it. So what you need to do is leave everything right now, immediately, and report that without making notes, you need to do it right away. Okay? So that is, you need to call 911 in that case. Oh, and call the doctor. Okay? So the healthcare provider. All right, so neuroleptic, because this is going to, the consequence of blocking neurotransmitters are going to produce a big imbalance. Okay? So the worst scenario of how this patient can die is because of the stroke and death. Why? Because the high blood pressure. High blood pressure, there's a precondition or pre-medical condition that they have hypertension or atherosclerosis. They can detach and produce a stroke, okay, and death. All right, so this patient need to stop smoking. To prevent this neuroleptic malignant syndrome, stop smoking because shorten the half-life of the drug, and we need to increase the dose. And that is one of the causes that the patient is basically having this problem. One thing, if you don't double dose, So this is not like a car race. No, you accelerate immediately, you have some results. No, this medication is going to take effect in about 2 to 4 weeks. All these medications, so it's not like a kick in right away. It's going to take some time, 2 weeks minimum. All right, so here we have, we are going to talk about the bipolar and antidepressants. Let's talk antidepressants first. This is very important, okay? Okay, so we have all the 4 here. TCA, SSRI, we have the SNRI too. SNRI, that is in between here. And we have the 3 cyclic acids are basically the oldest one. That was discovered on the what? On the 50s, right? 50s. It's one of the oldest one. Before, the treatment for mental disorders was really, you will be surprised, amazing. Very, you will say, brutal, almost criminal in the past. Okay, so another time, it's not the time to talk about it. All right, so here we have antidepressants are going to take about 2 to 3 weeks. So nothing is going to be immediate. It's not like a painkiller. It's not like a Tylenol or ibuprofen that you will see the effects in half an hour, according to the route. In this case, the therapeutic range is going to take about 2 to 3 weeks. Okay, so mostly all of them. Okay, even 2 to 3 months are going to need it in order to basically make full effect. 2 to 2 months approximately. Sometimes they ask you 2.5, 3 to whatever, right? So, but you know the range is in the range of more than 2 weeks or more, or 2 months or more, in order to, in the first one to start to make effect, and the second is going to be actually full effect. Okay. All right. So one thing I want to tell you here: all these antidepressants is very high yield for NCLEX. They love to ask about that. Suicidal ideas. Any antidepressant can need to consider that you can have suicidal ideas. How do you know the patient is having suicidal ideas?
Do they, maybe they isolate themselves more?
Okay, that is the
Or
person. What else?
they, oh, could it be that maybe they mention something to you?
Exactly. Yeah. So I was thinking just to jump out on the cliff. Or I was running my car and suddenly I was thinking, what about if I have an accident and die and forget about everything? Right?
Yeah.
All right. Okay, so the 3 cyclic acids, we have the imipramine, is the tofranil, is the most common, the imipramine. Imipramine. What is doing this, guys, is that 3 cyclic antidepressant medication is to, if you are depressed, so we are in the opposite side. You are depressed, you're down, so what you need to do is to increase the dose, to increase the neurotransmitter, to increase the neurotransmitter. So we have that the TCA, the SSRI, that is your super favorite Serengeti River we was talking about. SSRI means selective serotonin reuptake inhibitor. So remember, the serotonin is going to go into the synaptic gap, the space, and there is two things that happen here. They can go directly to the postsynaptic. They can three things directly to the postsynaptic. They can be eaten by the crocodile in the synaptic gap, so decrease the serotonin, or they can re-enter. They go back because they don't want to be eaten by the crocodile. So that is the three mechanism of action. So if you have low levels of serotonin, so they're going to give you more serotonin. They're going to inhibit the enzyme that destroy the serotonin, or they can inhibit the reuptake. Reuptake means the return of to the presynaptic. So blocking that, you're pushing the serotonin to pass to the other side of the river. So you have increase of serotonin. Is that clear or not?
Yes.
Okay. The monoamino oxidase inhibitor, MAO inhibitor, the MAO inhibitor is basically those crocodiles. Okay. The SSRI is going to be the reuptake, coming back, and the MAO is one of the crocodiles. They're going to destroy the serotonin, so you have more availability of what of serotonin. So tricyclic antidepressive, we have imapramine. We have the SSRI, Prozac, fluoxetine, paroxetine. Okay, SSRI, fluoxetine, paroxetine. So Prozac, Paxil. So most commonly coming Prozac. Okay. So please, I don't want you to get confused with the Ativan. What is Ativan? Ativan is the lorazepam. So Ativan is not Prozac. Okay. Prozac is antidepressant. Ativan is lorazepam, a benzodiazepine. Don't get confused on that. There is many students who can get confused on that. Okay? Write it down, please.
Okay.
Okay? And it's not the same. You heard of the Xanax. Xanax is the alprazolam. Okay, that is benzodiazepine. Nothing to do with it. So Prozac. How do you can remember Prozac? So some ideas. Okay, Prozac, fluoxetine. MAO inhibitors, that is used we use that in Parkinson, right? But it's an antidepressant too. It's antidepressant. That is the selegiline, is the Eldepril. We have the phenelcine. So those are MAO inhibitors. All right, so let's keep going here. Here in tricyclic acids, we have side effects. Don't mix it with alcohol. Because why? What happens if you take alcohol with imipramine? What happened? It's going to go more what?
Sedation.
More sedation. These guys are going to have actually an anticholinergic effect too. So you can say anticholinergic, everything dry. So you can tell dry mouth, retention of urinary, constipation. Okay. SSRI, we have the serotoninergic syndrome that we are going to talk in a few moments. All right. So basically, serotonin syndrome is when you have excess of serotonin. When you mix other medications that can increase the serotonin levels, can produce like storm of serotonin in your body. And you start to have this elevation of temperature again, known as a malignant neuroleptic, is going to be sweating, you have a tachycardia. So we will talk about that. MAO inhibitors, the very high question always asked. MAO inhibitors, remember, use your knowledge of Parkinson. MAO inhibitors do not mix with tyramine. Tyramine, 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 tyramine. Okay? Tyramine. Tyramine is going to be the food. Where are the food? And where we see tyramine?
cheese and wine,
Cheese and wine, excellent. And that can produce hypertensive crisis. That is mostly what we call hypertensive crisis. Okay, hypertensive crisis. So when you are going to change medication, you always, all medications, antipsychotics, antidepressants, all these psychiatric drugs, you cannot stop abruptly. You need to taper off. Taper off.
Thank you.
Oh, yes.
What is the antidote for hypertension crisis again?
It's dantrolene.
Okay, thank you.
Okay, so then we have the atypical is the bupropion. Bupropion. That is what I think they're going to be used mostly to quit smoking. Quit smoking. That is used for quick smoking. Okay, so let's keep going. All right, so now lithium, another main thing here. So we are going to finish soon this, yes, but I'm going to do the review. Okay, so the lithium. Let's talk about the lithium. Where is the lithium here? Okay, so I put it here and everything. Lithium is for bipolar. Lithium are going to be bipolar, migraine and clusters. Migraine clusters, okay? So you know the difference between migraine and clusters already, right?
No.
Okay, so very fast. Headache. Headache is all your head. Migraine, one side of the head. Migraine, one side of the head, but it's going to be progressively. So they are going to go from less to more strong pain. Okay with that? And cluster is on the same side, similar to the migraine, but the beginning is all of the sudden, boom, like a bomb. That is a cluster. Okay?
Okay, thank you.
Excellent. Okay. All right. So they are going to be used for bipolar. They're going to be used for combined by TCA, that is cyclic antidepressive for resisting depression. They can be in combination. The main thing here is, again, a rebound with V and F. Okay, so rebound effect. Okay, so be careful with the rebound effect, please. Okay. Okay. It's not MAO, it's MOA. Mechanism of action. So please, I don't want to get confused. It's MOA. Mechanism of action. It's not MAO inhibitor. It's MOA. Okay. All right. So here, the key priority for a nursing intervention is to keep hydration. To keep hydration. Keep hydration. Because otherwise you will reach toxic levels. So one of the main things that you're going to do in the patient with what? Bipolar, taking lithium, they are going to basically need to hydrate the patient because they can reach toxic levels. Lithium, okay, lithium. Lithium is like the battery of the lithium, they last long. So even though that the toxic level can last few days, more than few days, so they can produce problems with the toxic level. So we will see some signs and symptoms very soon. All right, so what you need to remember is, and I need to correct that because they changed, and I think I changed it. Okay, no, that's fine. It's 0.6 to 1.6. That is the therapeutic level. When it's 1.5, that is toxic. Write it down, please. So you need to avoid everything that produces diuresis. Makes sense or not, right?
Dr. G, you said 1.5?
1.5, yeah, toxic. 0.6 to 1.2 is the therapeutic range. Or therapeutic index, whatever you want. It's called therapeutic TI or TR.
Dr. G,
Yes.
if it's toxic, do we stop it right away or do we taper?
We taper it. We need, basically, this is a very good question. You need to basically hydrate the patient. You need to flush it out as soon as possible. Okay? Hospitalize the patient most likely because they need to monitor very close because they can produce suicidal ideas too. All right, so loop diuretics, alcohol, loop diuretics, coffee, tea, extreme sweating, extreme temperature, you can lead into dehydration. So your nursing consideration will be to ask the patient to take between 1 to 3 liters of fluid every day. Okay, increase the fluid intake. Okay, the lithium. Okay, so they can produce diabetes insipidus. Side effects can lead into diabetes. So it's increasing even more the risk for dehydration. Okay, we okay with that?
Yes.
Maintenance effects, thank you. Fine tremors, nauseous, polyuria, polydipsy because of this problem of diabetes insipidus. So they are going to basically urinate a lot, right? So, but that is not a sign of it's not a sign of what of diabetes mellitus. Okay, diabetes insipidus. Diabetes insipidus versus the secretion of inappropriate of the antidiuretic hormone. Do you see that in MedSearch?
Yes.
Okay, that is related to the ADH, correct?
Yes.
Now look at this. One is in excess of ADH. If that is in excess of ADH, is going to retain a lot of water. If there is low ADH, they're going to eliminate a lot of the urine, right? So when is low? Where is low? DI or SIADH?
Is it SIADH?
Excellent. And it's high in the ADH. How to remember that? You can tell me now, right? Two letters. A lot of letters. Few letters. A lot of letters. Easy or no? Right?
Yes.
Okay.
Yes.
Excellent. Early signs of toxicity, vomiting, diarrhea. All right, lithium can pass the placenta barrier. They can produce cardiac malformation. Epstein anomaly, one of my favorite pathologies to see. Okay, so Epstein malformation will be like the tricuspid valve go too low. So they have like what we call the Eisenmenger syndrome. So in addition, but Epstein anomaly. Just remember lithium bipolar. Imagine a woman having is bipolar, taking lithium. The baby can have cardiac malformation. That's all what you need to remember. Cardiac malformations. Okay. So that's for that we need to avoid the lithium, especially during the first trimester. All right, that is a summary. Okay, so that tricyclic, just another way to remember is cardiac arrhythmias, anticholinergic, and constipation. I don't know why Andy. Oh, okay, so those are the names for these guys. Andy, aminotryptyline, nortriptyline, disipramine, imipramine. Imipramine, aminotryptyline are basically very common. Okay? All right, so for that, we finish this portion, but before that, I want you to go over here. Just a moment. Okay, so let's go to antidepressants. Okay, so general considerations, please. Okay, antidepressants. So antidepressant means that you are going to elevate some neurotransmitters. All right, so no mix SSRI with St. John's wort. All this is HESI. I prepared this for your HESI. Okay, so MAO inhibitors plus any antidepressant actually can lead into serotoninergic syndrome. Serotoninergic syndrome. Why? Because all these MAO plus TCA, SSRI, NRI, so they are going to increase the levels of the serotonin. So they have excess of serotonin. So especially MAO. MAO inhibitor. No MAO with any other antidepressant. Okay? No MAO with any other antidepressant. Is that clear? Okay?
Yes.
So need 2 weeks in between to begin other medication. So you need to taper off. So even though you're changing medication, you stop the medication, cannot do that. You're going to need to taper off. Taper off. High yield for NCLEX. HESI. This is HESI. All right. So not even during the tapering. They can produce orthostatic hypotension, low blood pressure, everything low. We have suicidal ideas. They are going to be for a few weeks, 2-3 weeks. They are going to be, especially at the beginning of the treatment. The first 2-3 weeks is where you have suicidal ideas. So you need to check the behavior of the patient. Major risk between young women, 19 to 24 years old. Okay, so check for any new prescription. Always be alert on that because of the interaction. Sexual dysfunction, tapering, no abruptly stop. Drug make effect 2 to 4 weeks for a therapeutic range. Never double dose. And they are going to gain weight. So MO is most antidepressant. So I give you several mnemonics, just select which one is better. So this one I will say is directed for HESI. Okay, SSRI, the serotonin selective reuptake inhibitor. So we have the fluoxetine. We have sertraline, citalopram. Don't get confused with PAM. This is not a benzo. The SSRI, the prototype fluoxetine. Uses depression, anxiety, and PTS, post-trauma syndrome disorder, stress disorder, post-trauma stress disorder. All right, so side effects that improve after 3 months. So say several weeks that is going to have this side effect. After that, the side effects are going to go more control, less and less. Priorities, suicidal ideas. If you are going to stop, never abruptly. Serotonin syndrome, overdose. No, don't mix with St. John. Don't mix with St. John, okay? SSRI is antidepressive. So they are going to, basically what it's doing, St. John is calm you down. So if you have SSRI, you want to increase the serotonin. So you are doing the opposite with the St. John, okay? Don't make it change it or mix it with MAO inhibitors. No MAO inhibitors. Tramadol we will talk in the next slide. Serotonin syndrome. All right. Sweat, fever. It's not a sweat as hypoglycemia. So if they put you in exam, I will say EIQs. If they put you in the exam of EIQs, that is a clammy sweat. That clammy sweat is for diabetes mellitus. Rigidity, muscle and restlessness and agitation, tremors and hyperreflexia, tachycardia. So sweat and fever, tachycardia. So what is the sweat here? Sweat is basically you are floating your bed of sweat. You need to change the whole thing. So that means serotoninergic syndrome. SNRI. So SNRI is similar as the TCA. SNRI is a serotonin norepinephrine reuptake inhibitor. So this is similar as TCA. So, but this is more basically, they have less side effects. The names is the duloxetine. That can be used for depression and chronic pain, neuropathy, fibromyalgia. Fibromyalgia. So fibromyalgia, please just remark that. Okay, so side effects is improved after 3 months. So all these side effects are going to be for a few weeks, are going to have side effects, especially 2-3 weeks. But this SSNRI is going to take a longer. Patient teaching helps for chronic pain, improve sleeps in patients with fibromyalgia. I'm not depressed, I have pain. So that is telling you, I'm going to give you duloxetine. Oh, but this is for depression. But I'm not depressed. Yeah, but you have fibromyalgia. Fibromyalgia is going to be used this medication for that reason. Okay, fibromyalgia. Okay, SSNRI. So it's for neuropathic pain, similar as the gabapentin, right? That we don't know what is the mechanism of gabapentin, pregabalin, all this. So, but it's a coadjuvant, so it's going to use for pain in fibromyalgia. MAO inhibitors, we have the selegiline, okay, phenelcin, selegiline, L-Depril, depression, panic disorders, and social phobia. A mechanism of action is going to increase all these neurotransmitters. It's one of the oldest antidepressants. So we have hypertensive crisis, especially when you are taking thiamine. They can lead into myocardial infarction or strokes. Okay, so hypertension. So the consequence of that hypertension can lead into MI. No wine, no cheese, beer, salami, chocolates, no dry fruits, because they have high content too of thiamine. Okay, no dry fruit. You need to add that, by the way.
Dr. G,
Yes.
on one of your slides, it says to refuse if patient is not depressed but needs it for neuropathy, fibromyalgia for the
Yeah.
SNRI.
Yeah.
So you don't give them SNRI for
Antidepressive, yes, you can do that. It's used for antidepressive, but they prefer actually they prefer the SSRI.
SSRI for the
Yeah.
fibromyalgia.
No,
not the-
SSRI for antidepressant. So that's why SNRI can be used as antidepressant, but basically they're very common to use in fibromyalgia too.
Okay, because in one of your slides it says to refuse if the patient is not depressed but has fibromyalgia.
Oh, okay. No. In that example is the patient is receiving this SSNRI, and the patient knows that it's for depression, right? But he's not depressed. He says, "Why you're giving me? I'm not depressed. You're making a mistake." So this is patient education.
Okay.
You got it? We got it?
Yeah.
It's a very good
Yes,
question.
thank you.
Okay. All right. So don't mix. MAO is the big no to mix with other antidepressants, please, because they can produce a lot of problems, right? Suicidal. They're going to have the hypertensive crisis. Okay. All right. So the patient teaching. So very important. So when you are going to take the MAO inhibitors, you need to start doing the diet with no intake of these wine, meat, cheese, and dry fruits, and pickles or whatever. Those are contain a lot of thiamine 2 weeks before. 2 weeks before. You okay with that?
Yes.
Okay. The TCI is the imipramine, that is the prototype. they use for depression, anxiety, and neuropathic pain too. So they can be used for fibromyalgia. So we have two already now, SNRI and TCA, fibromyalgia. All right, so side effects, we have sweating, sedation, drowsiness, dizziness. Aminoptryptyline can produce orthostatic hypotension. Ipramin, anticholinergic effects. So basically all these antidepressive, they can have antidepressive, anticholinergic effect. So they have dry mouth, urinary retention, constipation, blur eye because there is dry in the eye, right? And this dryness of the eye can produce photophobia, by the way. Photophobia. Okay? So what are your nursing considerations in this case? Will be, for example, dry eye drops, photophobia, sunglasses, dry mouth, gums, constipation, you're going to have dietary fiber and fluids. All right, so we have the atypical, antidepressants, that is the trazodone, and bupropion. Okay, bupropion. All right, so that is uses for sleep aid and depression. Trazodone, it's Z. Can you see the Z? The Z is a symbol of sleepy. Okay, it's a sleep aid and for depression. They can be used to quit smoking. The bupropion are going to be to quit smoking. Trazodone is not trazodone, it's trazodone. No alcohol, like all other sedatives like benzos or antihistaminics, because they can increase effect. Take at PM because can cause orthostatic hypotension. Priapism, that is one of the things. Priapism, all these guys can produce priapism because they can produce can cause erection for more than 4 hours. So the erection, when they last more than 4 hours, become painful. And basically, they need to go to the emergency room. I have one case or two cases about that. That, do you know what we do? We fluid, flush it out, whatever, right? But we, in extreme, that is so stiff, so erected, that start to be bluish. Totally, and that can produce necrosis. So this is an emergency. So they can lose the organ. So what we need to do is to pinch with the needle the dorsal artery and evacuate the blood or take up blood. And that is going to calm down the pain. Yeah.
Dr. G, it's 12:10.
Okay. Let me finish here. All right. So I think I finished that. So here we have the summary. And for that, we are going to give you this in a paper next class. Okay? Today, after class. All right. So any question?
Not right now.
Okay. All right. So I will see you at 12:30.
Hello, we are going back at 12:40, okay? Okay.
Hello. I said 45?
Hello.
240, okay. Okay, hello everyone. Okay, so I was thinking to do something. On Sunday, I'm going to do like Super Sunday. I'm going to do like a marathon memorization for psychiatric. So I'm not going to release all my mnemonics today. Okay, I'm not going to release all my mnemonics because I was planning to do more mnemonics. So on Sunday is going to be very important. So basically what I have in my head right now that you're going to be very proficient in psych. So you're going to take hand of all mnemonics because you're going to pass to module 4, psych. And psych, they have all these drugs already there. Okay, so let's make it Sunday. Most likely it's going to be more than 2 hours, huh? Yes, I want to be sure on that. Okay? Okay, so any question?
What time are you thinking? Are you thinking in the morning or at night?
Wait, probably in the morning is better. We
Okay.
we can have we don't have sleep disorders like I do lately. So talking about sleep disorders, how do you sleep?
Not good.
Not good. Miss Anne, you how do you sleep? You sleep good? No. Who has insomnia? Like you insomnia? Oh my God! Yeah. So okay, you are my team. You're my team. Okay. So what do you want to talk now? What we are going to talk today? Sleep disorders. Okay? Sleep. That's what we need. Sleep. All right, so let's start. Let's get started. Cameras, please, on. Hillary, this is Virgin Islands. That's a Virgin Island.
What was that, Dr. G?
That is a Virgin Island.
Oh.
Okay. All right, so let's get started. Everybody's here? I see 3, 6, 8. Okay. Somebody knows about Chris? Chris Dillon? Nothing? He just evaporate?
Yeah.
That's not good. But anyhow. Okay, so I'm going to close this and then I'm going to go to this. My challenge is to make you proficient in all this stuff. So I'm going to make a really good plan for this Sunday. But it's different. I cannot do this kind of mnemonics to memorize faster because it's taking time. And I need to go over, sweep out all the material, and then I go into what is priority and what is anchors and guessing. So let's do that on Sunday. We okay with that? That's better?
Yeah.
Okay. All right, so without delays, let's start. Okay, so here we have sleep. Why do we need to sleep? Go straight. So 30% of your life, you are sleeping. Supposed to be sleeping like 8 hours a day, correct? But you're sleeping like me, for example, I sleep 3 hours and a half tonight. So I'm lack of sleep. And why? Because if you can tell the train of the sleeping process, sometimes sleep is like an obstacle to keep doing things, to keep studying, to keep you want to have 48 hours in a day, right? But you don't, okay? So what is the purpose of the sleep? Sleep is going to be, the time is terrorized because we don't know completely about that, but it's terrorized. That is the time that we use to repair our tissue, okay? To maintain, to create the thoughts. All your memorization are going to be established connections during the sleep time, okay? If you sleep less than 5 hours, that increased 3 times the risk for myocardial infarction. So who is in my club? Okay, so less than 5 hours, you increase your risk for myocardial infarction. So at least you need to sleep 5 hours. So you tell already everybody, no less than 5 hours. 5 hours, like the fingers of your hand. No less than 5 hours. Okay. Oh, what is this, Hillary? This is your place, no?
The beach?
Your Virgin Islands. Okay. And what you would like to do when you're in the beach? You would like to lay down on the sand, right? And put your head there to sleep. That's correct? And you make that facial expression because we are going to see sand is the neurotransmitters who are going to participate in the sleeping process. Nice? Sand, S, serotonin, A, acetylcholine, N, norepinephrine, and D, dopamine. So all these neurotransmitters are going to participate in the process of a sleeping process. We okay with that?
Yes.
Okay. So
Yes.
serotonin, for example, is going to initiate sleep. So a patient who is depressed can sleep? No, right? He's laying down, closing eyes. Everybody thinks that this is sleeping, but it's not. Right? Thoughts are coming and coming. Serotonin. Acetylcholine are going to be elevated. The only one who's going to be elevated, and that is during the REM sleep. REM sleep. REM. REM is the rapid eye movements. That is the time where you are basically resting to the maximum. Okay, so we will see that. Norepinephrine and dopamine. Okay, so let's keep going. Insomnia is the inability to sleep. When do you have insomnia? So insomnia, Anna, you was having insomnia. You probably have insomnia like 2 or 3 days, or 5 days. But that doesn't mean that you're not sleeping 5 days straight, right? You sleep here like one day, yes, the other day so, the other day you sleep better because you're exhausted, right? So sounds familiar, right? Okay. So what happened here is if you have a process, that process that you sleep, but then you don't sleep, and you don't sleep for 4 weeks, means insomnia treatment for 4 straight weeks. So that doesn't mean that you're not going to sleep 4 weeks straight, right? So I like explaining, okay? So 4 weeks of having problems with insomnia, basically coming and going, that is going to make you, you need to go to the doctor to check it out, okay? Not a disease. 95% of the people have insomnia once in their life, and that is about. So insomnia and common causes. Okay, so tell me how that looks for you. Huh? Pain? No, probably no. Anxiety? Yes, a little anxiety. Illness? No, you're not sick. Large amount of caffeine? Are you taking coffee? A lot, right? Large meals before bedtime? Okay, so lifestyle or environmental changes? Okay, lifestyle, so environmental changes. You're moving, that is a stress, right? So that is going to make you have some problems of sleep problems, right? All right, so look at this. Here we have the 3 most common types of insomnia. So where are you? Tell me, where are you? Initial difficulty falling asleep. So you go sleep You go to your bed and open eyes, you count sheep, you count numbers, you count clouds, turtles, whatever you want to count, and you are not able to sleep. Okay? Initial difficulty falling asleep. So you cannot sleep from the very beginning. You are like an owl. Second, intermittent difficulty. So you're going to you sleep, you wake up, and you sleep. You wake up again, and you go back to sleep. So if you are there, that is basically insomnia too. Okay. Now, if you have, for example, you sleep until 4 o'clock in the morning, like 3 o'clock in the morning, like me today, and then I wake up, that is me, terminal. So once I wake up, I cannot go back to sleep. Yep. So there's two situations. And for that, you have different treatments, different drugs. Okay. So that's why we need to know the types of these. All right. So sleep fitness. So that means patient education. The night should be kept on to help patients to get bed safely. So that means that you don't want to have heavy, strong lights. You don't want to have strong lights because your body, your brain is going to think, oh, it's morning already, wake up. No. And that's why when you go to the bathroom, especially at night, you have a very attenuated, soft light. Because if you have an intense light, the body is going to think that it's time to wake up. Okay? So, all right. Getting out of bed if unable to fall asleep. That is NCLEX. Previous is NCLEX. This is NCLEX again. So, if you cannot sleep, the recommendation is to stand up, to go out of your bed for 20 minutes. Okay? And they do something that relax. And, for example, take a glass of milk, warm milk, okay? Some milk, some juices, something that make you feel more relaxed, okay? And after 20 minutes, try to go back into your bed. No large meals, because that will increase insomnia, okay? Here we have some situations here. That is a circadian rhythm that is going to promote the release of glucose at night. So when you have glucose at night, you stimulate different hormones. There is basically that's in a study of 2006. So, but I'm not going to that. So go to the point. No large meals because you cannot sleep. Okay, no large meal, you can't sleep. Alcohol. How many of you? No. How many you know that when you go to bed you want to take a glass of wine or a shot in order to go to sleep? Do you hear that?
Yes.
And that help or no? You will do it? Somebody say yes already immediately. No? Excellent. Why? Why? Because as you read there, the alcohol produces a fragmentation of the sleep. Fragmentation of the sleep. Yes, you can go sleep for the next few minutes after drinking your alcohol, but then you're going to wake up. Tell me one thing to the next level. If you sleep straight 6 hours, let's put it this way, 6 hours. 6 hours, straight 6 hours. And then you, another day, you sleep 2 hours straight, and then you wake up 10 minutes. And then the next 2 hours, you sleep. You go back to sleep for 2 hours. And then in the next 2 hours, you wake up. And then 10 minutes, you start to awake, and then you go to bed, to sleep. So you sleep basically all the 6 hours minus 10 minutes 3 times. So tell me, when you wake up in the morning, you feel the same or different?
Different?
Different. Well, how you feel, Hilary? How a patient should be feeling?
If you have a straight 6 hours, you feel good versus when you keep waking up.
So how are you supposed to wake up in the morning?
Energized?
Excellent. They said, "Oh my God, this is my chance to go to Gurmik Academy." Okay, and said, "Yes, full energy in the morning." Okay, so that means, in conclusion, that you rest enough. You totally, your muscles during the night are relax. Your muscles are not moving, so they are relaxing and without activity, and that gives you the feeling, sensation of that you are rest. You have very much a good rest. So now you are full energy. Okay. Okay, so that is a reason. I signed up for a reason, and I will tell you why. Because here we have the cycle, the sleep cycle, a sleep cycle. The sleep cycle, we have here the REM and no REM, the REM and no REM, the REM and no REM. The REM means rapid eye movement, and the no REM is no rapid eye movements. So here we have that the REM is like, please remember this, REM is the gold, is your treasure, is your pearl, is your diamond during your time of sleeping. Because that is the moment where somebody came, okay, that is the moment where your muscles are totally relaxed. Totally relaxed. So that is the time that you rest the most. Okay? What is that period? Is the REM. We have a stage 1, a stage 2, 3, and 4, and the 5, there is no 5, but it's REM time. REM. REM. So we have four stages, and the REM cycle. So it's in the REM where you're going to start dreaming. Oh, you know what? I was dreaming yesterday. I was flying. It's a nice dream, right? Do you dream flying before?
Before, yeah.
Before? No, now why? Okay, all right. So I just dreamed that 2 days ago. I was flying on my wheel. Anyhow, so that is the dreaming time, dream stage, the REM stage, REM. So tell me, which stage you swim? I mean, you dream?
REM?
The REM stage. Okay. So from all these, there are going to be more deeper sleeping in at the level of stage 2, stage 4. That is where you have the deepest sleep, but I didn't say the deepest relaxation. Okay, so stage 4. Stage 2 is the largest stage. Is the largest stage. And listen to this: the drugs for sleeping aids for sleep basically are affecting stage 2 and stage 4 too, but stage 2 the most. So that is when you're taking sleeping pills. It's going to make it longer, the stage 2, but not the REM. The REM is going to be the same. So tell me again, based on what I told you, if you sleep cutted 6 hours, for 6 hours, but you is being cutted, it's the same to sleep based on what I show you here, like straight 6 hours? You need to answer why.
Why?
Yeah, okay, I will tell you. This is why. Look at this. Here we have look at this, REM, stage 1, 2, 3, and 4. So remember, REM is when your eyes are moving, moving, right? And that is the time where you have the maximum relaxation of your body. And at the same time is the time where you have your dreams. All dreams that you have, you remember, is in REM. Now look at this. Look at this graphic. So this is 1 hour, 2 hours, 3 hours, 4 hours, 5 hours, 6 hours, 7 hours, 8 hours awake. And look at this. Look at this. Stage 1, 2, 3, 4. Deepest sleep. So the first hour, look at this. They go to reach stage 4. Deep sleep. And then you come back and then go back. But they don't go all the way down. So they're going to go more superficial during that time of sleep. And then you wake up. Okay? All right. So now, what happened with the REM, the REM? Look at this. The first hour is about 5 minutes of this completely relaxation of your body. The next cycle is a cycle. So 1, 2, 3, 4, REM. REM, then go 1, 2, 3, 4. And then go back. 4, 3, 2, 1, REM. The next REM is going to take 15 minutes. The next REM is going to be about 30 to 60 minutes. So that is what you want to reach in order to have, at the end of the sleep time, a very nice rest. You totally feel rest on the morning. We okay with that? So what is the problem here? What is the problem here? The problem is this. Look at this. 5 minutes, 10 minutes, 15 minutes. The more cycles you have, you accumulate more REM. The more REM you have, the more happy you will find out yourself in the morning, with more energy, ready to jump to go to Garnick Academy. Okay? But now look at this. What happened if I going to wake up after 3 hours? After 4 hours? What happens if I wake up at 4 hours? Because I have insomnia. So I'm going to go back to bed, but instead to continue to the next 30, 60 minutes of REM, I need to start all over again. See the difference?
Mm-hmm.
Okay? So that means that you have 5 plus 10, 15 minutes. Plus 15, 30 minutes. Plus 60, you have 1 hour and a half about that is going to be completely relax your body. So instead of that, so 1 hour and a half, if you wake up after 4 hours, you will have here 5, 10, 15. So you wake up, go back again, 5, 15, half an hour. So you will rest 1/3 of what's supposed you to rest. 1/3. So that's why in the morning you wake up tired. Oh my God, I need to go again, right? So because of that. We okay with that? Okay. So question is, excellent. Question is, can I make the sleep, can I make myself sleep with pills and tablets and have the same effect of this natural sleep cycle?
No?
No, right? So what happened is this, that most of the drugs are going to make longer stage 2, leaving less time for REM. So any treatment, any sleep aid is going to replace the normal time of sleeping.
Dr.
Right?
G,
Yes.
can you go over again the difference between the stages? Is it just like how relaxed the person
Yes.
is?
No. This is how deep is getting sleep. The
Okay.
relaxation you obtain it on the REM in these red dots, red areas.
Okay.
You're relaxed here, but you have the highest relaxation at the level of the REM.
Okay.
Okay? All right. All right, so REM, sleep restores mental and physiological balance, and we have 2 types of drugs, sedative and hypnotic. Sedative to calm you down, hypnotic to what? To induce sleep. And there is another group of drugs that are going to be both sedative or hypnotic. Okay, so the sedative, what is doing, these sleeping pills are going to decrease the amount of REM cycles. So you have less number of REM. You have less REM cycles. Okay? So you can increase the relaxation, and basically you need to assess the patient for anxiety. Anxiety have a background of release a lot of cortisol, adrenaline, and that's going to make you awake. Hypnotic, total sleeping time, they are going to affect stage 2 and 4. So taking more time, because one cycle is about one cycle is going to be from 0 to 1.5, 1.5 to 3, to 3 to 4.5, every 1 hour and a half. So what they're doing is to make longer the stage 2 and the stage 4. So the 8 hours is going to be short to produce more REM. Is that clear or not? So there is no drugs that can improve your REM so far, or what I'm aware of.
So,
And
Dr. T, the drug mostly affects stage 2 or stage 1?
4, 2 and 4,
2 and 4, okay.
2, 4. That is a melatonin. Remember melatonin? The Dracula hormone?
Yes.
At what time appeared Dracula?
At night?
Excellent. See? So the melatonin is going to appear at night. REM stores mental and physiological balance. We already talked about that. Okay, hypnotic is going to substances. We are going to talk today. Benzodiazepines again. Yes, benzodiazepines. Benzodiazepine was a minor tranquilizer or anxiolytic. Okay, it's going or sedative. That is the. But if you increase the dose, they can have hypnotic effects. In this case, you're going to, when that happens, you sleep longer, but you sleep because your stage 2 and 4 are longer. So that's what is going to happen. Oh my God, I need some coffee. I'm sleeping. I don't need to sleep. I'm the opposite right now. Okay. Check baseline. So you already know quiet environment. Do you have TV in your bedroom? Don't have TV in your bedroom. Okay, because I don't have TV. I have a screen, 72 inches, whatever, Alexa, but I'm not using. Everything is internet. Okay, so because why is that?
You can't, like, your body might think that, because the light will make,
The light of the TV.
the light will make you awake.
Yes, excellent. So the TV is going to have some lights, and that light is going to get into your eyes, and your body is going to sing. Your hypothalamus is telling everybody, "Oh, we are in the morning. Wake up, everyone! It's time." But it's not. All right. So no sedative hypnotic agents in patients with sleep apnea or respiratory difficulties. Okay, so you don't want them to make them sleep and they have apnea because they can produce some very rare but can happen deaths. All right, so sleeping pills, many elderly people, and we don't know. Paradoxical is that we don't know how has this happened. So we expect something and it's occurring the opposite. And that mostly happen in elderly people. Okay, so do you know Batman?
Yes.
Okay. Batman is treated with insomnia. Batman is not sleeping all day. And for that, they're going to use Batman. B benzodiazepines, A antidepressants. Then we have BT trazodone. Trazodone. Trazodone is Z, like sleepy, melatonin, right? The pineal gland. Antihistaminics, they are going to make you sleep. Doxylamine. Doxylamine is always coming. And then here we have the no benzodiazepines. Okay? Okay.
Okay.
Okay. One thing here. Okay, so what are you going to do here? Look at this. Batman, B benzo, A antidepressant, T trazodone, M melatonin, A antihistaminic, no benzodiazepines. Excuse me, can we have 5 minutes? I need to make a coffee, okay? So I'm just too much insomnia. Okay, 5 minutes. 18 are going to be here.
Okay, thank you.
Sure.
Okay.
Okay, let's continue. All right, so the benzodiazepines suppress the REM, but not as much as the barbiturates. The barbiturates are going to last longer than the benzodiazepines. So think about in the terms of the barbiturates are going to be having long acting. As a consequence of that, they are going to be more toxic. The barbiturates, I think it's class 2, right? Barbiturates, schedule 2, right? Okay. So here we have the residual daytime sedation, headache, blue vision, impaired coordination. So they're going to make you have these hangovers. The benzodiazepines, basically, they're going to do is have hangovers and have some amnesia from the last few hours before you go to sleep. Okay, so are actually, we are going to see here some examples. Benzodiazepines, we have the alprazolam, the temazepam, we have the triamzolam, and basically what I want you to write down these things, please, okay? Okay, so just a moment. Okay. All right, so let's go to the alprazolam. Alprazolam is for anxiety. Alprazolam Xanax for anxiety. And when you have anxiety with depression. Then we have, let's see, the temazepam. Temazepam is used for insomnia too, but as a pre-medication. I need to write down something here too. The midazolam. All right, so no, let's do these names only, because they are going to be basically using for different. I'm going to organize in different manner. All right, so they are going to use antidepressants sometimes when insomnia is moderate. Okay, so antidepressant, we have the trazodone. Trazodone, just make a C here, C, sleep. We have the doxepin that is coming from previous year in HESI. Doxepin, so it's an antidepressant. It's not used for antidepressants for depression, but have the same activity because of the neurotransmitters that we was talking before. They are going to promote sleep. And doxepin, don't forget that, doxepin. Trazodone, that is similar as the TCA, but they definitely produce, there's been used especially for insomnia. Melatonin is the ramelton, always coming for the NCLEX, is troubles if you fall asleep. To fall asleep. So that means that if you are going to bed and open eyes all night, melatonin. Let's go here. Okay. Antihistaminics. What is the problem with the antihistaminics is that they can produce drowsiness next day. These antihistaminics do not produce any dependence, but they can actually have a tolerance. So these antihistaminics, when you do these sleeping pills, the sleep aid that you have in OTC, in over-the-counter medication, they are going to be limited. So if you use it for long periods of time, like let's put it more than 1 week or 2 weeks, the antihistaminic will not make effect. And antihistaminic, remember, in respiratory, antihistaminic have some anticholinergic effect too. All antihistaminics, they have some anticholinergic effect. So dry mouth, retention, urinary, constipation. Now, let's talk about the no benzodiazepines. Okay, so before that. So what is the mechanism of action of the benzodiazepines? Increase GABA. GABA is a neurotransmitter, is an inhibitor neurotransmitter. Okay, it's an inhibitor. And they can produce dependence, the benzodiazepines. You need to carry it no more than 4 weeks. And when you are going out of the medication, you need to taper off. Taper off. Okay, so we have here the benzodiazepines affect the hippocampus and cerebral cortex to cause anterograde amnesia. Anti means before, right? So whatever you was doing few hours before you take the pills, it basically is out of your. It's difficult. It's not like you have amnesia. It's like you are more difficult to try to remember things. And probably some of you already just noticed that in some patients. Now, benzodiazepines, huge, please. Liver toxicity. Liver toxicity. They can produce hepatotoxicity. So you need to check for jaundice. Jaundice. Okay? Benzodiazepines, smokers may require largest dose. Medications need to be taken before bed, not in the morning. You don't want to actually try to go to bed in the morning. Safety precautions, as you know, machinery. Okay? And they can produce dependence. Question, huge for NCLEX. NCLEX tip here. The flumazenil. Flumazenil. Open eyes, open ears. Flumazenil is the antidote for all benzodiazepines. We have cross-dependence. For example, that is when one drug suppresses the withdrawal signs and symptoms of another drug. For example, if you are having alcoholism, and you have withdrawal syndrome, and you take the benzodiazepine, and you need to take it for some a long period of time, that means that all addiction, alcohol potentially can replace with another one. So you become dependent to the benzodiazepine. Okay, the benzodiazepine are going to be, for example, the benzodiazepine are going to need to be tapered off no more than 4 weeks. Remember that. Can develop paradoxical responses. So instead to you take the benzodiazepine and nothing happens, you be even more time awake. That happened in less than 1%. Mostly happen in elderly patients. All right, so a missed dose will trigger withdrawal syndrome, which would include anxiety, insomnia, sweating, tremors, and dizziness. So nursing considerations for taper off the benzodiazepine. All right, so here we have what I was trying to look here is the midazolam. Midazolam is used for minor procedures, where is when you want to calm the patient, sedate the patient, but you need the patient to follow some directions, some orders during the procedure. Example, the endoscopy. Avoid grapefruit because they are going to increase the effect of the. When you take grapefruit, some cases they are going to decrease, some cases are going to decrease the effect. In this case, it's going to be increasing the effect of the benzodiazepine. Lorazepam, the Ativan. The Ativan is going to be having this retrograde amnesia. All right, so don't take it with food because they can decrease the absorption. Another one I want you to remember here is the clonazepam. Clonazepam is going to be used as anti-anxiety and for panic attack. Clonazepam, panic attacks. Do you see that? in the market?
Yes.
Unison, right? That is the phenylephrine here and the doxylamine. So those are the Unison sleep tablets or nighttime sleep aid. Sleep aid. Okay. All right. So they have tolerance, as I mentioned. So these antihistaminics can produce tolerance, and actually, what can produce is an opposite effect at the end. Increased dose can increase restless and irregular sleep pattern. None of these, there is no medication at all who can increase or keep the same number of time for REM sleep. None. So basically, all these pills are going to help you, but you feel this tiredness at the morning, next day. Trazodone, this is a serotonin modulator. Okay, they can cause is used as antidepressant too. Is TCA, tricyclic antidepressant, but if we used to for insomnia. All right, so here we have the no benzodiazepines. The no benzodiazepines are having here solpidem. I'm sorry. So what is the difference between benzodiazepines and not benzodiazepines? The benzodiazepines increase GABA. GABA. The no benzodiazepines increase GABA too, but they're going to be more specific for certain receptors. So we have GABA A, GABA B, GABA C. So we have many other receptors, and these receptors are it's more selective, let's put it that way, than no benzodiazepines. They have actually lower risk of abuse and dependence than the benzodiazepines. So that is much better than that is actually we use better than the benzodiazepines. Solpidem. So everything that says sa, so, sa, solpidem, saleplom, esopiclon, okay, Ambien, Sonera, Lunesta, okay. All right, so if difficult, maintain the sleep. So if you wake up at night and then you cannot sleep, solpidem. If you go to sleep and you cannot go back to sleep, saleplom. And the esopiclon is difficult to initiate the sleep time. All right, so the same thing here. So all these, you need to get used to the name hypnotic. Hypnotic is basically a medication that induce or produce effects to sleep. Chlorazepate. Yes.
The non-benzodiazepines, they're not addictive, right?
Yes, there's no addictive as the other one of the benzos. Yes.
Okay, thank you.
Chlorazepate, another NCLEX tip here. It's a benzodiazepine, but never is used because they control seizures. Anxiety is not popular because it's potential addiction and withdrawal seizures. Okay, so chlorazepate, just ban that, but you need to get familiar with it. We don't want this. No benzodiazepines, they have less effect on stage 2 and 4. It's 3 and 4, so 2 and 4, huh? 2 and 4. And REM sleep cycles. For short term, about 7 to 10 days is used. Ramelton, the melatonin, 30 minutes before go to bed. So please be careful with the liver. Be careful with the liver. So, I need to sleep. I take 3-4 pills. No, because they can produce some problems on the liver. Now, sedative herbs. We cannot use sedative herbs, St. John's wort, because that is going to increase the effect. Okay? St. John's wort is always coming. St. John's wort. The barbiturates. Barbiturates are going to produce much more hangover than the benzodiazepines. These barbiturates basically we can use as sedation to induce coma. There is many, so they can be used for insomnia, yes, is not that common, you can use this for induced coma. When do we induce coma? We induce coma in order to make sleep for several days the patient. Example, when you have a head trauma, or intracranial pressure is increased, they actually induce coma. And that resting is going to help to regenerate the tissue and is going to decrease the intracranial pressure. What happened? Oh, okay. What is this? Oh, yes. All these are the wait, just a moment. Okay, it's the phenobarbital. So if you see here, all of them are going to be called phenobarbital. Barbie. All are Barbies. Right, so no alcohol because it's additive effect that combine barbiturates and cause more central nervous system depression. So those are depressors. You cannot mix. That is a general thing. You cannot use depressors and other depressors, including the alcohol. Okay? Let's talk about epilepsy. And this is where we are going to have seizures. Okay? Are you ready? Okay.
Yes.
Okay, so I'm not going to go. You did already seizures, epilepsy in MedSearch?
Not yet.
Okay, so I'm not going to go into pathophysiology because the time is very, 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 very short. So what I'm going to do is going directly to the classification. So I'm not going to talk about epilepsy, so I'm going to do the classification. Okay, so look at this. So we have classification of the seizures, the partial or focal, generalized. So listen to this. What is a seizure? A seizure is a convulsion. But convulsion is not necessarily seizure. Okay, so I explain myself. So convulsion is basically the erratical movements, shakiness, extensions and flexions of upper, lower extremities, body in general. That is a seizure. Convulsion, sorry, convulsion. Convulsion. That is convulsion. Convulsion is this radical movement, whatever part of your body, okay? You okay with that? Now, what is a seizure? Seizure is a shortcut at the level of the brain. There are seizures that are coming without convulsions. Make myself understood? Seizures not necessarily is going to end in convulsions. Seizures, we have, for example, seizures that are for absence of seizures, seizure absence. So absence means that you are looking at a person like me right now. Look at this. I'm talking, and then suddenly, ten, 15 seconds, and nothing happened. So that is what you saw right now was a seizure. But I was having convulsions? No. All right? So
No.
convulsions is what you physically can see that is moving part of the body. Seizures is a shortcut on the brain. They can end into convulsions, yes. But some of them do not. Is that clear or no?
Yes.
Okay. All right, so let's go to the classification here. We have partial or focal, and they're going to go, and we have the opposite, focal and generalized. The epilepsy, the classical one, is generalized. The partial or focal is going to be when part of your body is basically moving. For example, I'm going to take a cup coffee like this, okay? And then I'm going to have a partial seizure. So, and then what happened when I talk, I going to drink or when I going to drink, my hand is doing this. Throw the glass, throwing the glass. Or when I going to eat, I going to eat and my spoon go somewhere. Erratical movement. You didn't lose consciousness. It's just one rapid movement. Or you're sleeping, and then suddenly your arm is doing this, like that. That is a seizure already. Okay? All right. So we have partial and generalized. Just put it in your mind. Partial and generalized. Why it's important to know that? Because you're going to know all the names of the anti-epileptics right now. Okay, so we are going to classify, and there is like 20 drugs that are going to be known today. But if you know 1, 2, 3, 4, or 5, that's it. So you know which drug will correspond to what. And they are going to ask you, this drug is for partial or generalized seizure. So let's start. So just remember, partial, and what is the opposite? General. Partial or focal, and the other one is the generalized. Okay? Now, the focal are going to be divided in simplex and complex. Okay? Simplex and complex. So we have the focal seizure. That means that start in one hemisphere. In one hemisphere. Complex means that they go from one hemisphere, then go to the the other hemisphere. So it's going to happen first in one hemisphere, and then they go to the next hemisphere. We're talking about the cerebrum, correct? So that is simple and complex. That is focal. Focalize, start in one place and stay there. That is the simple. And the complex is when they start from here and they go to the other side. That is complex. You okay with that?
Yes.
And generalize is the classical epilepsy, is going to start in both hemispheres. Okay, so can you tell the difference, right? No?
Yes, like
Yes.
headache and migraine, right? Similar.
Well, yeah. Let's see. Yeah, for the head. Well, the headache is in both sides, right? The generalized is both sides. Now that is generalized. The focal start always in one place. If they stay here, it's actually simple. If they go from here to the other side or vice versa, they're going to be complex. Okay?
Okay, thank you.
All right, so here we have the classification of seizures. So basically, you're going to remember this. The absence petit mal. In the past, it's called petit mal, some still calling like that. Petit mal. Petit means what? Small. Tonic-clonic means grand mal. We have myoclonic, we have tonic, we have atonic or akinetic. Okay, so what is this? Tonic means tension. So all your muscles are going to contract. Clonic is when you have basically tonic is when you have this contraction, flexion like this. And clonic is when you have flexion and extension. Clonic. Tonic. Then, so that's what you can say. Myoclonic, for example. Myo means muscle. Clonic is extension and flexion. So you're going to do this, like this. Like I was telling you, that is a myoclonic. That is a seizure. We have the atonic. that is one is not a common, but happen that you start walking and suddenly you lost the strength of your muscles. Boom, you just drop on the floor, fall on the floor. Tonic is when the contractions are going to be in your body, upper, lower extremities, neck, face, right? Tonic. And all this is going to last about 20 seconds. About 20 seconds. 20 seconds is about the time that all these seizures are going to last. The absence of petit mal is when you are basically talking and suddenly you stop talking and you are totally not moving. But you don't lose the equilibrium. It's amazing, right? You still whatever position you are, but you don't lose equilibrium, you don't fall down. All right, so tonic-clonic grand mal is the classical one. And for that, let's talk about it. All right, so we have generalized is the petit mal. Example, absence. Absence, seizures of absence is about 10 to 30 seconds. Loss of consciousness for a brief period and usually involve eye blinking and staring into the space. Okay? Mostly happen in children and can disappear during the puberty. So, succinamides, that is the first name you need to remember. So, put in the back of your brain, of your mind, all the classification. Now, let's go straight forward. Seizures of absence is going to be succinamide. Okay, so just remember this. So just remember this. Seizure of absence sucks. Sucks or no? Yes or no?
Yes.
Yes.
So seizure of absence sucks. Succinamides. That's it. Okay, so for tonic-clonic, we are going to see that there is an aura, that is the aura stage. This is the ictal stage, and the post-ictal stage. So we have 3 stages. This grand mal, the grand mal is that you have the feeling that something is going to occur, something is going to happen, some event, bad thing is going to come over. So, and then start to have the seizures. There are going to be 90 seconds is a little bit longer, 20 seconds, 30 seconds is about the average. And you lose consciousness because all the vessels are going to vasoconstrict. You fall down, you start to have these tonic-clonic movements, and you need to be with the patient. Don't leave the patient alone. Don't put your fingers inside the mouth. Put the patient in solid floor or area and try to protect the head, and try to hyperextend the neck and put it on the side. Do you see some seizures before? It's very impressive. Huh? The first time, it's very impressive. The first time is very impressive. The second time, no, because you have a duty. You need to do something. Okay, and there's a lot of saliva. It's like you putting detergent on the mouth. A lot of saliva, and make this grounding. This is like sound of that is very impressive. Like this, and scissoring at the same time.
Dr.
Okay?
G,
Yes.
you said to put for tonic-clonic, put the patient on the ground.
Yes, in solid surface,
Solid surface. Okay.
and try to protect the head in order not to have traumas.
And then we don't try to restrain them, right? We just let them.
No. Just to
Let them.
control, not
Okay.
beat himself on the floor.
Okay.
All right, so there is many things that can trigger out the epilepsy, okay? So especially fever, especially sound, intense light that is going to produce that trigger out the seizures. Just remember, all these medications, basically all of them that we were talking, antidepressive, anti-epileptics, they can produce suicidal ideas, very high yield for for NCLEX. Taking for life, the medication is for life. Epilepsy can appear one time and then appear after 10 years. Depends. So there is variations. They can appear every month, every week, every year, every 10 years, every 5 years. So you always need to be alert. All right, so no stop abruptly the medication because they can produce a rebound effect. Okay? All right, so let's go to the drugs. That is what I want to go with you. Okay, so, all right, so, okay, so here, another one. So, Primidone, just remember that name. Please pay attention to me. Primidone, memorize that. Primidone, generalize seizures. Topiramate. So you know the prima donna. A prima donna is on the top of the news. Okay, Topiramax and primidona or primidone. The prima donna is Latin, right? So the famous diva, whatever, right? Prima donna is on the top. Okay, so those are for generalized seizures. Okay. We have the valproic acid. The valproic acid is the Depakine, that is the oldest anti-epileptic, and that what is doing is for focal and generalized. That is a very common drug. So it basically is all terrain. You can have focal, simple, complex, generalized, but any of the seizures can be used valproic acid. The problem with valproic acid is this: they can lead into spina bifida. So contraindicated, especially in the first trimester. You okay with that?
Yes.
Carbamazepine, another name that you must remember, please. Carbamazepine is the Tegretol. This can be used for seizure, they can be used for generalized and focal seizures. And this carbamazepine is used for migraines too, can be used for migraines. And trigeminal neuralgia, another high yield, by the way. Yes, general neuralgia. Trigeminal neuralgia is a cranial nerve number 5, very painful. One of the worst pains that a person can have is trigeminal neuralgia. All right, so they are going to produce a Stevens-Johnson syndrome. I wish I could have more time to talk about that. A Stevens-Johnson syndrome is very high yield for the exam. A Stevens-Johnson syndrome is what we call, is going to appear some vesicles on the skin. So as soon as you detect that, you need to actually report immediately because it's life-threatening. So those are ulcers appears over the skin. That can happen for how to suspect that? Any lesion that is painful and new, that probably is Stevens-Johnson. And that is caused by carbamazepine and other drugs that we are going to memorize later. Carbamazepine, I highlighted here because it's very common. Now, let's talk about another drug that is the phenytoin. This phenytoin is a lot, so we need to just go over here and I will start to be satisfied. But idantoin is the phenytoin. Toin is very toxic. Toin, toxic. So the range is going to be 10 to 20 micrograms, very narrow therapeutic index. So that means that there is very high risk to have toxic levels. Now, if your levels are less than 10, risk for seizures. All right? If you have more than 20, they are going to have toxic levels. And the toxic level, we are going to see some of the problems: hepatotoxicity, nephrotoxicity. Okay, the idantoin. This is carbamazepine, same for idantoin. Okay, so now check routinely labs, laboratory tests. So after you administrate the medication, you need to check labs after 1 hour or 2 hours to check the therapeutic range. After that, you're going to request until you reach the therapeutic level, you're going to request one every 12 to 24 hours. Okay, so that patient are hospitalized. Okay, so all right, so let's see here. Steven Johnson too. So carbamazepine, we have the idantoin, the phenytoin, Steven Johnson. So that is what happened. Steven Johnson. They can produce all these lesions because spread out of the skin can produce severe infections. They can go into septicemia. Steven Johnson syndrome. Remember, all these drugs, antidepressive, anti-epileptics, mostly all of them are going to have suicidal ideas. So you need to check for behavior changes. Another thing, gingival hyperplasia. Gingival hyperplasia. This is actually expected. Gingival hyperplasia means an overgrowth of the gums. It's going to get swollen, even bleeding, but that is expected. So you don't need to call the physician for this. Okay? This is expected. Everything that is expected, they need to basically, you don't need to call the healthcare provider. So we promote oral hygiene. You need to teach the patient that when they have dental work, they need to educate the patient to tell the doctor that the patient that they're taking the phenytoin or idantoin. Okay? Now, we have bradycardia, hypotension, idantoin. Hypotension, bradycardia, that is expected. Now, another important thing, phenytoin, decrease the effect of the OCPs. So you must change the method of contraception. OCPs do not affect the phenytoin levels, but you don't want to have an accidental pregnancy. Okay with that?
Yes.
Because they can produce the fetal idantoin syndrome. Microcephaly. Look at this. This is the normal head size supposed to be. And look at the head. Microcephaly. Okay, mental retardation plus cleft palate. And Epstein disease here. Malformation. All right, so this can cause hair on your face, like a beard, in girls especially. Succinimide is for petite absence, petite mal, absence seizure, succinimide, absence. Status epilepticus. Status epilepticus is when you start more than 5 minutes seizuring. Okay? And basically the patient, well, it's not seizuring, is the patient do not recover consciousness. So once you have in the post-ictal, the patient, post-ictal means the seizures stop. And what happened is that they start to feel tired, exhausted, very tired. And but it's already kind of, have LOC, yes, but is actually responding. But in this case, the status epilepticus is going to be not responding, and actually there are going to be multiple seizures, one and again, and is not recovered from consciousness, not recovering consciousness. So the first thing we are going to give is diazepam, 5 to 10 milligrams a vial, IV, and that stops the seizure, diazepam. Phenobarbital. Phenobarbital, 2, is to sedate the patient. So for that, I want to go over this. All right, so I'm going to go over the name of the drugs, and with that we finish. Just a moment. There you are. Okay, so those are the name of the rest. We are going to see that next class. Okay, so look at this. We have all the names that we was talking, correct? Okay, so look at this. We have this focal or partial. That is focal, the simple and the complex, right? And we have the generalized, all this circle. In between, there's a crossover that are going to be for focal and generalized. So from all these 20 drugs that you're going to remember, you need to remember generalized only are going to be the topiramax and the primidone. That are the only ones who are exclusively for generalized seizures. Then you have for generalized and focal are going to be the phenytoin, phenobarbital, valproic acid, and carbamazepine that I was remarking very much. Carbamazepine, valproic acid, phenobarbital, phenytoin. This is a derivative of phenytoin too. So phenytoin, phenobarbital, valproic acid, carbamazepine. These drugs can be used for focal and generalized. The rest of the names that I mentioned, all of them are for partial or focal. Okay, so if you remember 1, 2, 3, 4, 5, 6 of these names, you know very good, you have an idea of what is happening with these drugs. Okay? We okay with that?
Okay.
Okay. So I think on Sunday is a must. So we need to have at least 4 hours. Okay, so it's going to be a super, ultra, hyper, super Sunday. All right, thank you so much.
Dr. G, what time on Sunday?
Saturday, you have something on Sunday?
We have clinicals on Saturday.
Until what time?
Our clinicals are from 6 to 1.
At night is going to be at 11, right? Okay. So what I'm going to do for that day is this. I'm going to summarize my plan.